Hey, Wen. Hey, Wen. Welcome.
Agora sim. Tudo bem? Peraí.
Now I can hear you.
Okay. For some reason I cannot unmute myself, and
You can. I can hear you fine now.
yeah, but
And
for some
also,
I
reason.
made you co-host. Then you can unmute. So you would
Okay. Oh,
possibly.
that's why. Oh, thank you. Thank you, Imad.
good to see you, Wen.
Good to see you too. So mesial surface
Mesial
of the brain.
surface. Yes.
Wonderful.
Wonderful. Let's see.
Yeah,
Let's see. Say
will be
this
wonderful.
afterwards.
Okay.
We have
So
already tested. Me and Imad, we shared and we tested I think everything is working fine. So we have 10 minutes to go. If you
okay. This gossiping.
Let's start.
Yes, but actually, yeah. Now we are getting used to Zoom webinar.
Mm-hmm.
So every time, each time we'll do it will be better than the
That's
previous
true.
one. That's
That's
wonderful.
true.
Yeah. Mm-hmm. And mm,
And I was mentioning we are seeing um, uh, pretty much people who has been with us every Friday. I have
oh,
said
really?
hello. Yeah, yeah, pretty
Wonderful.
much, pretty much. We already recognize the names and they are always around. That's good.
Okay. Yeah. We try to advertise, the webinars over the Instagram, Rhoton International Rhoton Society,
Right. Vanessa
Instagram.
has been doing a great job on
Yes,
that.
yes. I think this is very important. So
Hmm.
people will know what we are doing.
That's right.
So I think over the time, for the next few months, the audience will increase because more people will get to know that we are
Hmm.
running webinars. In the
Hmm.
beginning, it will be smaller audience as expected, but it's okay. To remember, as Dr. Rhoton said, all the effort in his life just to save one patient
True. Very
will
true.
be worth it. Yeah. So it's obviously more people will be, more satisfying, but just for one will be worth it.
Mm-hmm.
I kept
One
remembering.
wheeling is okay.
Uh-huh.
And I've noticed that it has already been increasing on skull base and also
Yes,
on
that's what I'm
peripheral
expecting.
nerves.
Gradually people will get to know.
Mm-hmm.
In
And
the
Friday
beginning,
is
it's hard.
becoming anatomy day, truly.
Yes, yes. And they canceled the skull base meeting um 2 weeks ago. Probably everybody's on vacation in Europe.
Mm-hmm.
So maybe, and also the Olympics, the trouble they're having,
Yeah.
you know.
It's starting today, right? At 2
Yes, the ceremony.
for us. For us.
Yes. Uh-huh. For them, this tonight.
Mm-hmm.
But they're having problems with the problem with the trains and you know.
I haven't had that time to check what happened, but I heard something
Yeah,
had
some in
happened
the
with the
airport,
trains.
trains, transportation. They try to sabotage the Olympics. Somebody's trying to sabotage. This is too bad.
Mm-hmm.
So probably, Sebastian is kind of busy. Uh,
Yeah, I
even
imagine
though in Europe,
so.
yeah, even though in Europe is they're on vacation, but he's not in vacation on vacation.
Mm-hmm. Probably working even more.
Yes, probably. Mm-hmm.
Just like us here with the World Cup, right? We worked like crazy.
Mm-hmm. Yes.
So
Oh,
probably the
wonderful.
same. But I
Mm-hmm.
didn't know that in 2 weeks they won't be doing. They will skip then
No, no,
August.
no. The 2 weeks ago they skipped.
Mm-hmm.
2 weeks ago they agreed to not to run just for 2 weeks ago, but the next month will be back on, I guess.
Mm. Well, wasn't it jugular foramen, the last one?
The
I
jugular was
thought
gone. Yeah, they did.
they did
Jugular
jugular
foramen.
foramen.
The one
Mm-hmm.
after jugular foramen. So they
It's good.
decided
Oh, okay. Okay.
just 2 weeks ago.
Mm-hmm.
But it's okay. Next month they'll be back
Right.
because they have a very good number of audience
Mm-hmm.
for
Mm-hmm.
Scope. It's
And
very.
more than one people talking, and the time frame is broader, so I think people can handle things and come in at some point, or come in and skip out if they have work or something to do. So it's longer than I think people can manage better time
Maybe, maybe.
to arrive.
Yeah, maybe. They will speak for 15 to 20 minutes each, and then
Mm-hmm.
it's gonna be usually they are 5 people or something. So if
Yeah,
one
that
was
was
good,
the thing in jugular from I think 5 people
yes,
talking.
since the beginning,
Mm-hmm.
they've been doing this since the first webinar. This is
Mm-hmm.
a good
I
good
think it's a
model.
good yeah, good model. Yeah.
Mm-hmm.
I'm only concerned a little bit about time because Friday is still hectic, so people have to be juggling around to be able to
Mm-hmm.
participate.
Mm-hmm. Okay, almost time. 4 minutes.
Almost time.
I will stop chatting. I'll just wait. I'll just wait for you to
Sure.
get started. Okay.
Okay.
Does anybody want to talk to Carolina? Now it's time. We have 4 minutes. Ask her
Hello,
something.
everyone.
Yes. So noon for you on Friday. It's okay.
Yeah, some Fridays. I have been arranging the other days of my week to be able to be in the meetings on Friday. They have been very
Mm-hmm.
good.
Okay.
But usually I am in the middle of something. But the timing, I think, for everyone is a little bit good because it's noon for us, and then end of the afternoon for people in Europe, and then night, not so late for people in Pakistan and on.
That's good.
And then Asia is about to become, I think Japan is about to become Saturday. So
Yes.
I think it's a compromise that in the end fits the bill.
Yeah. You cannot, the time cannot be wonderful for everyone, you know. It's
This is why Imad is going to replay tomorrow, right?
yes, that's why. Because now probably it's around 11 p.m. in Japan, in Taiwan, and midnight in Japan.
In Japan, right.
Yes, something like that. So
I think it's 8 in the night for you, Imad. It's around
Yes,
that.
ma'am. It's 8 p.m.
Yeah.
not so bad. And Europe is 5 or 6 hours ahead, so maybe 5 p.m., 6 p.m., something like that.
End of the week, maybe.
Mm-hmm.
Hopefully. I'm going to be sharing my screen, right? When I
Okay,
think
go ahead,
I
please.
won't
Go
be
ahead.
able to be seeing you, but I can hear you all.
Okay.
Let's see if what I am sharing.
You can do your introduction yourself, you know.
Oh no.
You're the boss. Don't. I was just watching, okay? I was
I'm
just
not the
watching you.
boss.
You're the boss, okay? Till you do the introduction, everything else. Okay, wonderful.
Okay, let's see if I can make it presenter mode. It's okay for me. And can you see my screen?
Yes.
Okay, and my audio, is it good? Everyone is listening okay? Thanks,
Good.
Imad. Thank you very much. Hello, everyone. I think it's about time. Let's see if we still have a few minutes to go. 1 minute to go. And now we are on time. And I am here with Dr. Wen, and this is one more Friday where we are discussing anatomy for surgery, and this is the partnership between the World Federation and the International Rhoton Society. And today I have been helping with presenting everyone, but today I am presenting myself. So I think you already see my screen. We are going to talk about the medial surface of the brain. And last month we did talk about the basal surface, and we will be having the lateral surface in a few weeks. All of them we are seeing on that initial idea that Dr. Wen gave us of seeing through the skull, through the head of our patient to be able to access and to treat them better. This is our main idea, to make neurosurgery safer by using our anatomy knowledge. And I do have to thank Dr. Wen. This is an old picture, and this is Rhoton's lab family, and you see Professor Rhoton there with Alice and Wen and Cecilia together, and also our director, Ron Smith. Wen and Cecilia are, I consider them my elder brothers in Rhoton's family, and I am always grateful, not only for all the opportunities that they give me, but for their friendship. And I am very glad, I and my family as well, we are very glad to have them in our lives. And I usually present this slide when I'm talking because I am grateful, and I have been learning with all these people. Sometimes the slide doesn't hold all of them. The list is enormous. And of course, I only met and learned with these people because of Dr. Rhoton. So he did made a very important change in my life and in the life of my patients. of course. And in the subject we are going to talk today, which is the medial surface of the brain, we are going to dig in the work not only of Professor Rhoton, but also of a Brazilian neurosurgeon, which is Professor Ribas. Both of them, Dr. Rhoton and Dr. Ribas, they worked with perfecting the idea that we can use a template to see through the skull to the brain and locate things that are helpful for us in surgery. Both of them worked pretty much on the lateral surface, and today we are going to try a few ideas that they have proposed and a few that we have expanded over the years about the medial surface of the brain. So this is the way that the surgeon looks at the brain. We know the basic anatomy, and we want to arrange this basic anatomy in a way that we can use that instantaneously in surgery. So we are going to apply that to the medial surface of the brain. This is our subject today. We know this surface is, most of it is flat. We know that the bottom part is curved. It's curved from medial to lateral because of the skull base where it adapts. It also is concave in the bottom part, especially on the most posterior border between the medial surface and the basal surface. They are different. Yeah, we have a border here which is truly has a shape of a border, but in the posterior part is almost as if the border is inverted, and we know that that is because it adapts to the falcotentorial junction. So we recognize the shape of this surface. But if we want to pick a template, if we want to pick an idea that we can use to understand the medial surface of the brain, maybe a nice idea is to think about a roll cake. And in my region in Brazil, there is a very famous roll cake. And the roll cake, as you see, have layers separated by filling. And if we keep this idea in mind and now look at the medial surface, we will start to recognize a little resemblance. And it is a roll cake. The inner part, the most deep part or the core is formed by the thalamus. The ventricles are arranged around the thalamus, so we inside that. Then we have a layer which is a connectome layer. In fact, is the layer that gives all the shapes embryologically, which is the corpus callosum. And the corpus callosum is separated from the next layer by a sulcus, which is the callosal sulcus. We can follow the callosal sulcus in this image. And the next layer, this intermediate layer, is the cingulate gyrus. If we look at the cingulate gyrus from this subcallosal area where are the paraterminal and the parofactory gyrus, and we follow it all the way to the isthmus, then we realize that it is pretty much almost a continuous layer, separated from the outermost layer, again by a sulcus, which starts under the rostrum of the corpus callosum, which is the cingulate sulcus itself. And we understand that this intermediate layer has a lot to do with the limbic system, right? This is another talk that we can arrange to have, but keeping the idea of the medial surface in mind, then we get to the outer rim or the outer layer in this roll cake, which is the medial surface, which is the outermost layer in this area. And this outermost layer, it holds some limits. Two parts of it are limits between the medial surface and the basal surface. In the posterior part, this is given by that corner, which is not acute corner, inverted corner, and this corner is given by the lingual gyrus. The lingual gyrus is limited by the calcarine sulcus, and the calcarine sulcus receives this other sulcus here, which is the parieto-occipital sulcus. And because of that, the lingual gyrus is larger in the middle part, and it is as if the calcarine sulcus has a hump. So this will form the border, the posterior border between the medial surface and the basal surface. At the anterior part, of course, the border between medial and basal is formed by the rectus gyrus. We are used to see the rectus gyrus as we saw last month from the basal surface, but it goes all the way to this surface. It extends to the rostral sulcus. The superior rostral sulcus is the limit of the rectus gyrus here. In this specimen, the inferior rostral is inside the rectus, and the superior rostral sulcus, notice it meets with the cingulate sulcus. And from that point on, it becomes the medial frontal gyrus. We say medial frontal gyrus in this surface, but we will remember that it is called another name in the lateral surface. This medial frontal sulcus extends all the way to approximately the middle point between the genu and the splenium of corpus callosum, where the cingulate sulcus gives a branch. Sometimes it's bifurcated like this because it's involving the medial prefrontal sulcus, and this branch is the paracentral sulcus of the medial surface. It helps us see the ending part of the medial frontal sulcus and the beginning of this block of tissue, which is the paracentral lobule. The paracentral lobule, in fact, is the part of the central lobule, the pre and the post-central gyrus, that are passing to the medial surface. They are limited. They receive the central sulcus. It usually imprints the upper border of the hemisphere. So we have this very eloquent area here. And this paracentral lobule ends at another branch of the cingulate sulcus, which is not anymore the paracentral ramus, but now is the marginal because of the border, marginal ramus of the cingulate sulcus. And from that point on, another piece of another chunk of brain starts, which is the precuneus. Please notice that the precuneus, it is separated from the intermediate layer, cingulate gyrus proper, again by an extension of the cingulate sulcus, which is the subparietal sulcus. Sometimes the subparietal sulcus enters the precuneus and bifurcates, like in this case, and the precuneus extends all the way to a very deep sulcus, again a sulcus that indents the superior border of the hemisphere, which is the parieto-occipital sulcus that we have just seen, reaching the calcarine sulcus. And between parieto-occipital sulcus and calcarine sulcus, we all know we have precuneus. So this is the outer layer of the roll cake, which is the medial surface of the brain. Those are the names that we give to these chunks of brain in the medial surface. However, we all know that they are the same tissue, precisely the same tissue that we see when we are on the lateral surface. But sometimes we forget that because we give different names when they are seen from the lateral surface. So that medial frontal gyrus, when we are seeing the same piece of brain tissue on the lateral surface, this is the superior frontal gyrus. Some authors reserve the idea of the medial frontal gyrus just to this part, which is medial to this sulcus, not all the time present. When it is present, this is the medial frontal sulcus, but most authors agree that the medial frontal gyrus and the superior frontal gyrus are pretty much the same tissue. So when we see in the lateral surface, we say superior frontal gyrus. When we see on the medial surface, we say medial frontal gyrus. What about paracentral lobule? When we see on the medial side, paracentral lobule. When we see on the lateral surface, we recognize pre and post-central gyrus. This is the central lobe, which is a concept that neurosurgeons adopt, although this is a concept not adopted in regular anatomy. So we say the central lobe because it's functionally very important to us, very eloquent to us, but it's not a real lobe in anatomy. But we will keep in this talk speaking about the central lobe and the paracentral lobule. So it corresponds to it. So you started to notice, I believe, that the sulci that come from the medial surface, in that idea of the roll cake, is as if the roll cake is rotating in high speed because the sulci are coming out tangentially and getting the border of the hemisphere. So we already noticed that the paracentral ramus marks the ending point between the medial frontal gyrus and paracentral lobule. We mentioned that the marginal is the division between paracentral and precuneus. Now we are seeing that the precuneus is the piece that extends all the way to the parieto-occipital sulcus and incisura. The sulcus usually leaves an incisura in this area of the body, and it corresponds to the superior parietal lobule. So it's the same chunk of tissue, of brain tissue, the superior parietal lobule and the precuneus on the medial surface, as much as is the same chunk of brain, the precuneus and the superior occipital gyrus, as well as the lingual gyrus and the inferior occipital gyrus. And we say that because the medial occipital gyrus is usually shy, doesn't get to the pole, the occipital pole, so we can see the correspondence very well when we look at the hemisphere in this position from a basal view. So this idea that the medial surface is like a roll, it works for the gyrus, it works for the sulci, it works to remind us that the medial surface in the outer layer is the same as lateral surface close to the border of the hemisphere, aligned along the midline in the area of the sagittal suture, in the area of the interhemispheric fissure. So the interhemispheric fissure, in fact, is a cleft, an fissure, which is between these two surfaces of the hemispheres, the medial surfaces of the hemisphere. They comprise this upper border mostly. This space is partially divided by the folks because the folks, especially in the anterior area, doesn't get all the way down to the bottom of the interhemispheric fissure, as we will see. And topping these folks, as we know, is the superior sagittal sinus. And we understand that the superior sagittal sinus is a collector of superficial veins in the lateral surface that will join the superior sagittal sinus along the lips of the interhemispheric fissure. And with this image, we can realize that some areas, the veins that get to the superior sagittal sinus, they reach the sinus differently. Please notice that the most posterior area, close to the occipital pole that we were just checking, has very few veins, cortical veins coming to this area. When they happen, they are very small. Although to the most posterior and upper part, they become very important. Look at the pre-central and the post-central veins. They get really big and important. some surgical result depends on this, and they get into the sinus in an angle which is pretty much against the flow, if you notice. But when we get to the most anterior part, the veins, they reach the sinus closer to 9-degree angle, so it's easier to work between the veins in this area, while here the veins, many times they are parallel to the sinus themselves. So working along the medial surface usually has to use this surgical avenue, which is the pericallosal cistern through the interhemispheric fissure. And it's truly a deep dive. We need to go down from the upper border along probably 7 to 8 centimeters, all the way to the bottom of this space that you see here in whitish, and is the dorsum of the body of the corpus callosum. This is what we are seeing. It is a space that I said partially divided by the folds, and the layers of the row, they are on our sides. We have to have the precise instruments. If we have too short superficial instruments, we won't get to the bottom of this space, this surgical avenue, which is the interhemispheric fissure. And when we are working there, we need to remember the arrangement of the layers of the row. We need to remember that they are the same chunks of bone that we see on the medial surface as well as on the lateral surface. And in truth, we can see all of that in our radiological, our imaging of the brain. We can see the layers, the sulci, we can realize all of that in our pre-op imaging. So we can get to this space very well prepared. But does this idea of the row work also for the vessels? Let's check. Here we have the angiograms that are filling the anterior cerebral artery as well as the middle cerebral artery. See that they have a point where they meet this frontier area. And the anterior cerebral artery, the distal part of the anterior cerebral arteries, they do make the turn, and they do have a part of supply in this border layer of the lateral surface, as well as they supply the medial surface that we will explore. They are, in fact, the distal ACA, right? Because we say distal because it's beyond the anterior communicating complex. And if we look at a profile view of this area with those glasses that I have been trying to put on you, that these areas formed in layers, we are not seeing sulci, we are not seeing gyri, but we start to recognize that there are similar arrangement here, including that idea that the vessel also is spinning in high velocity and goes through the tangent in the roll cake to reach the lateral surface. Let's examine. We will be following the anterior cerebral artery, right? And we know that the distal anterior cerebral artery is also called the pericallosal artery. It usually courses in one of the sulci that we mentioned. It courses along the callosal sulcus. So we can start to see the layer of the callosum as well as the intermediate layer. The most important branch that comes from this distal ACA is the callosal marginal artery. We also know that it runs along in proximity to the cingulate sulcus. So now, by looking just at these two branches, we start to see all the layers. We don't have brain here, but we are pretty much recognizing the brain structures just by seeing the arteries, just by using the same template that we were working with. And if we go forward and looking at the sulci that we were mentioning before, the inferior rostral, superior rostral, the area of the parolfactory sulcus, we will understand that many times the distal ACA branches in this area, occupy the sulcus, sometimes one distal ACA in the concavity of the other, and the orbitofrontal artery usually marks the one of the rostral sulcus, while the frontal polar artery again marks the other one. So we are pretty much being related to the brain by looking at these areas. And it follows that the branches, the group of the internal frontal branches, the anterior, the middle, which is usually not present, but in this specimen, in this patient it was, as well as the posterior internal frontal, they are supplying the superior frontal gyrus that we mentioned. And when we get to the middle part of the body of the corpus callosum, midpoint between genu and splenium, that we have the paracentral sulcus. Also in the vascular part, in the arterial part, we have the appearance, sometimes straight from the pericallosum, as in this case, as a branch that's coming out from the internal frontal. Together with the internal frontal, the posterior branch, we have the paracentral artery. We know that the paracentral artery goes to the paracentral lobule, many times gives a branch that marks the paracentral sulcus itself, and it supplies this area. So I can, by recognizing the arteries, relate to these areas that we know. And the most posterior part, the precuneus, between the posterior ramus as well as the parieto-occipital, that becomes very deep. Then again, we have the superior parietal artery, as well as the inferior parietal artery. They will be present, supplying this area, making the border between the paracentral as well as the cuneus. But then those sulci, they become very deep, right? They become like crevices, deep ravines. And that signifies something, that means something. It means a change in function from the most anterior part of the medial surface and the most posterior part, but it also means an arterial change. An arterial change because the territory of the anterior cerebral artery is ending and a new territory is starting along these two very important sulci, the parieto-occipital and the calcarine, and the meeting that they will make along the para-hippocampal gyrus. So notice that the parieto-occipital sulcus meets calcarine, and it is like a thunder dividing, splitting this gyrus, which is the para-hippocampal gyrus, in isthmus as well as lingual gyrus. So running along this area is another territory, another artery, that will give supply to the medial surface, to the posterior part of the medial surface. And it's another territory because now we have the presence of the posterior cerebral artery. We all remember that the posterior cerebral artery, behind the brainstem, it usually gives its cortical branches. It's the collicular point. We mark the position of the brainstem when we see the PCA get behind the brainstem, and then it gives its two P4 branches that will be the parieto-occipital artery and the calcarine artery, all of them reaching those deep sulci that sometimes, like the calcarine sulcus, reach the edge, the outer layer of the ependyma of the ventricular cavity. And these sulci that reach the ependyma, we call them complete sulci. So the calcarine sulcus is a very deep sulcus, so deep that it indents the ependyma, and because of that we say it's a complete sulcus. And the P4 branches of the PCA go all the way close to the end of the sulcus. They travel in these very deep ravines. As we see, the cortical branches will follow the parieto-occipital as well as the calcarine sulcus. So the appearance of these deep sulci, they mark the changing, functional change, arterial change, but it also marks the change of the drainage. We saw that initially that upper part of the medial surface is drained by the veins that come from the medial surface as well as the lateral surface and meet at the superior sagittal sinus. But when we get to this area, the system starts to change because the importance of the deep venous system of the brain formed by, at the velum interpositum space, by the internal cerebral veins, by the basal veins that are receiving their tributaries like this one, the inferior ventricular vein, and several veins that come from the calcarine fissure, like the internal occipital vein, as well as the posterior splenial vein, they will all drain to this deep system of veins. So the presence of the sulci also marks a change in the drainage of the medial surface. So this idea, which seems like odd at first, right? That the medial surface is like a roll cake and have layers. It works embryologically because whenever the corpus callosum is missing, we don't have this organization. It helps us remember that we are dealing with the same chunks of brain. We can check the sulci that delimit the layers in our pre-op imaging. It also works in the vascular sense to remind us of important changes that happen also in the arterial as well as in the venous area. But does it help us in surgery? Is this template, be thinking about the medial surface as a roll cake, does it help us when we have to deal with the skull, to remove a specific part of the skull, to enter through this, the interhemispheric fissure, to reach the cistern, the pericallosal cistern, and to operate our patient? Well, we have seen that some templates help us very much. If we remember, this is a very common image from Dr. Rhoton's book, and as well is mentioned in the key sulcal points in Dr. Riba's works. Both of them, they do rely on a line which comes from the nasion, the midpoint at the frontal nasal suture, all the way to the uppermost point of the external occipital prominence, the inion, to organize our idea about important sulci that define the lateral surface. But does the nasion-inion line helps us organize our ideas to be able to look at the head of our patient and see the medial surface? Let's check. If we get most of the approaches done to lesions along the medial surface, we will see that those approaches, they will fall into 4 sectors. 2 anterior sectors, subcallosal and supracallosal sector, as well as 2 posterior sectors, dorsocallosal and retrocallosal sectors. And it is as if we are getting the roll cake and separating the areas that we can reach the roll cake, the outer all the way to the center of the roll cake based on 4 sectors. If we can transpose these sectors along the nasion-inion line, we will have a way to see through the head of our patient and see the medial surface instead of seeing the lateral surface. So let's check each of these sectors. The subcallosal sector is very frequently used, right? We use this sector when we want to reach lesions that are comprised within the anterior part of the cingulate gyrus, especially lesions that pass along the rostrum, along the genu of the corpus callosum to the other side, butterfly lesions. We also get to this sector if we want to reach the anterior communicating complex, even if we want, and even more if we want to reach lesions, vascular lesions, which are not at the level of the genu, but are under the genu, next to the rostrum. And if we do that to vascular lesions along the anterior communicating complex. This is the view that we will get. So it will be useful. It will be a little hard initially to get proximal control, but it's possible. And we usually do that if we, especially if we have related, associated lesions, like lesions in the carotid bifurcation. So it will be useful for lesions like that. We can also go deeper in the layers of the row, right? We can see the lamina terminalis. We can open the lamina terminalis. You all remember that the lamina terminalis is the anterior wall of the third ventricle. So we can open to free CFF in this area. Or we can even do a communication between the ventricles and the cisterns. And if we want to do that, we don't want only to open the lamina terminalis, but we want to get into the third ventricle beyond the chiasm, which is here, and we want to go to an area anterior to the mammillary bodies, and beyond opening the lamina terminalis, as we have done here in this specimen, we also want to open the floor of the third ventricle. Just anterior to the just posterior to the infundibulum and anterior to the mammillary bodies, using the microscope that has been described since the 50s. But if we want to go beyond that and work inside the third ventricle, in the core of the row cake, we can then get our endoscope, and passing beyond the mammillary bodies, we can go to the posterior part of the third ventricle. We can recognize the posterior commissure, we can recognize the abenular commissure, and we know that between this one and the floor of the third ventricle will be the opening of the aqueduct. Between this one and this one is the pineal recess, and above the abenular commissure is the suprapineal recess, which is closed by layers of tila, which are hanging at the roof of the third ventricle. With the endoscope, we are only seeing from the bottom up. And we can recognize the choroid plexus hanging along the roof of the third ventricle. And we can see all the way again to the mid part of the ventricle, where there is the interthalamic adhesion, which is probably the best name for this structure. Some other people call it interthalamic adherens, or mass intermedia. Usually the interthalamic adhesion is the best because it is just the point where the thalami get together. If we have hypertension inside the third ventricle, they will separate and the interthalamic adhesion will disappear. So it's a marking really of hypertensive changes in this area if the interthalamic adhesion disappears. So to perform a subcallosal approach, we need to plot that on our skull, and it's usually plotted along the tangent line that gives us the rostrum, and it usually corresponds to the initial 25% of the Nasion-Inian line. So most of the approaches that go subcallosal to this sector, they will obey this posterior limit, which is the posterior 25% of the Nasion-Inian line. What about the supracallosal approaches? Those are even more common, right? We do get to this area anytime we have a lesion which is medial to the superior frontal sulcus. So we will use a supracallosal version of an approach. We will apply this sector. If we have a lesion in the layers here, and if we have a vascular lesion which is coming out from the callosal marginal at the level of the genu of the corpus callosum. In fact, inside the supracallosal approaches, we do use a structure which is within this sector, which is the medial-most part of the coronal suture. I say the medial-most part, the part that it crosses the sagittal suture, because if you notice the coronal suture, it veers anteriorly. But if we obey to this initial area, this initial 3 centimeters of the coronal suture on each side, and we have this coronal plane, we will recognize that it matches the foramen, interventricular foramen. It will match the limit between the frontal horn and the body of the ventricle. This is why we use the coronal suture as a surrogate for most of our approaches on the supracallosal side. And by using this area of the coronal suture, we enter the pericallosal system. We will go all the way down to the bottom of the system that, as we've seen, is this whitish area, dorsum of corpus callosum, very different from the vascular laden aspect of the cingulate gyrus, intermediate layer of our roll cake. We will get anteriorly all the way to the genu. See that the branches are coming out here. We also see the callosum marginal coming out here. And we can, if we want to enter the ventricle, which is pretty much a useful way to use the supracallosal approaches, we can count 1, 2.5 centimeters, and we will start our opening of the corpus callosum in this area. We want to limit this opening the less we can to see what we need to see, and we enter in this area of the interventricular foramen of Monro, which is between the frontal horn and the body of the ventricle. And whenever I see the choroid plexus in this area and I see the thalamus striate vein, I mention this because many times we are operating this in a hypertensive state. So when we open the callosum, what happens is the other ventricle may still have pressure inside, and they will push this very thin layer, which is the septum, towards this side, covering the foramen. So many times what I have is this one vein and the choroid plexus. If the thalamus striate vein is to the right of the choroid plexus, I am on the right ventricle. I also mention that because many times we, especially if you are a right-handed surgeon like me, we tend to go to cross midline and be in the left ventricle, and we need to guide themselves with the anatomy. So we have already recognized the choroid plexus, the thalamus striate. We know the septum is a very thin layer, and it can collapse toward us. We see the interventricular foramen, the caudate, the thalamus. We recognize the fornix, and we can then choose where we want to go in the innermost layer, in the core of the roll cake of the medial surface. We can enhance the opening of the choroidal fissure by enlarging the foramen of Monro, or we can open the choroidal fissure all the way to the body of the ventricle. And by doing that, we will again be opening the third ventricle, now from above, now from the body of the corpus callosum. And what we have just seen in the subcallosal approach, that is the cisternal side of the lamina terminalis, now we are seeing from above, from a supracallosal approach, we are seeing the ventricular surface of the lamina terminalis. This is why we see the reddish and bluish hue, which is given by the anterior communicating complex as well as the communicating vein. So we are seeing through the lamina terminalis here. This is the anterior commissure. So we have the anterior wall of the third ventricle all the way delineated to the chiasm and the suprachiasmatic recess. We are seeing the infundibulum. We are seeing the area where we can do an opening at the floor of the ventricle, and we again recognize the mammillary bodies. And we all do that based on the coronal suture, and we usually say that it's a craniotomy which is 2/3 in front, 1/3 behind the coronal suture, and this is just one example of a supracallosal approach using the concept of this sector that goes, the limits of this sector goes from a quarter of the nasal inion line all the way to the 50% of the medial of the nasal inion line. And what does the 50% stands for? Notice that it's a little behind the coronal suture, right? And it stands for the anterior limit of the dorsocallosal sector. The dorsocallosal sector, as you remember, is the sector which is behind the end of the superior frontal gyrus. That ends, as we all know, at the precentral sulcus. That can be at the border as a medial precentral sulcus or a marginal, as in this case, precentral sulcus. And the precentral sulcus will be separating the portion which is not anymore supracallosal, but now dorsal callosal sector. And it will be the anterior limit of the paracentral lobule and the central lobe itself. We can use as a surrogate to this marker, we can use a well-known landmark in the lateral surface. We can use the meeting point between the superior frontal sulcus and the precentral sulcus that we know is anterior to the central lobe. And we all know that this point is well seen in the radiology, the imaginology exams of our patient, and it marks the anterior part of the limit between the precentral and the postcentral gyrus. It is usually 1 centimeter behind the coronal suture, 3 centimeters lateral to that, and on the medial surface is equivalent to the paracentral sulcus, which is 50% of the nasal inion line. So what about the dorsocallosal sector? If we want to understand the approaches of the dorsocallosal sector, we need to understand the sulci that limit this area. We mentioned the paracentral ramus of the cingulate sulcus, and all the way it goes to the parieto-occipital sulcus, that deep sulcus that marks, indents the border of the hemisphere. The parieto-occipital incisura, which is this point that marks the border, has a very clear relationship with the lambda. Dr. Ribas has taught us that. It many times is the same level as the lambda or 1 centimeter behind or above it. So it usually has this relationship, and we say it is 75% of the nasal inion line plus 1 centimeter. So if I want to delineate the borders of the dorsocallosal sector, I can use these landmarks. But we also understand that this dorsocallosal landmark, that this dorsocallosal sector is formed by 2 very different areas, right? In eloquence, I mean. The paracentral lobule, we will only get there if the lesion is really there because it's very eloquent, but in very different from a less eloquent, it's not that it's not eloquent, but less eloquent precuneus or superior parietal lobule. So I can divide the lesions along the dorsocallosal sector by finding the limit between the paracentral lobule and the precuneus, and this limit is given posterior by the parieto-occipital line and anterior again by another sulcus that indents the border. If I find this sulcus, which is the marginal ramus of the cingulate sulcus, I can do an oncological resection of a lesion which is comprised within the superior parietal lobule, and that will give me a very reasonable result. It makes sense to remove lesions in this area. To do that, I need to know where the marginal ramus is. As we said, it is anterior. It's a marking on the border, which is anterior to the parieto-occipital, so anterior to lambda, and also at the most posterior part of the central lobe. So it will be aligned with the postcentral sulcus. It is usually along this most lateral the diameter the largest diameter of the head from lateral to lateral, which is the areon. So if I look at the head of my patient from above, from superior normal, I can see the largest part from lateral to lateral. I will have a very good idea of the coronal plane this point is at, and it is at a point where the intraparietal sulcus meets the post-central sulcus. It will be around this coronal plane. That is also possible to see in the imaging of my patient, that I call the bracket sign, and is the feature that gives a bifurcated aspect to the post-central sulcus in this area, especially easy to find between the areon on each side, the largest part from lateral to lateral. So I can have an idea, and that point is 50% more, 3.5 centimeters. So I can also plot, be more specific in the dorsocallosal sector if I want to remove only the precuneus and lesions in the precuneus. What about the retrocallosal? The retrocallosal is a very fun sector, right? It goes from the parieto-occipital sulcus all the way to the inion, all the way to the skull base in this area, comprising the calcarine sulcus. So it will be this segment from 75% plus 1 all the way to inion. And it comprises the cuneus, as we know, between the parieto-occipital and the calcarine sulcus. And when we get to the calcarine sulcus, just after having seen the coronal plane that obeys to the areon, the largest part from lateral to lateral, please notice that the calcarine sulcus also abuts to the surface. It's also a marginal sulcus, and it's usually at the largest, not lateral to lateral, but anterior to posterior diameter of the head. So in a region that we call the opistheon. If you notice, and if you pass your hand on the back of your head, you will notice that the inion is not the more distant point in the anterior to posterior area. That is a little above. That is the opistheon. So the calcarine sulcus will mark the border of the hemisphere in this area, and it is around 3 centimeters above the inion. So I can find the callosal sulcus. So I can use this idea that I can find the callosal sulcus, the parieto-occipital sulcus, to use the dorsocallosal sector to remove lesions in the cuneus, to remove lesions in the lingual gyrus, like this one. Please notice the calcarine sulcus and the largest anterior to posterior diameter of the head. Please notice the parieto-occipital and the relationship with the parieto-occipital sulcus to check, and remove a lesion like that becomes very easy, very simple, very rewarding for us, the patient, and their family. We can also go not only to the outer rim, but going to the intermediate layer, lesions located closer to the isthmus, like this one. This is the occipital pole. Here we have the area of the sagittal sinus and the transverse sinus. So I position the patient in a way that the occipital pole falls by gravity, helping us to reach and remove the lesion, which is deeper along this area. Not only can I reach deeper in the anterior posterior sense, but I can also use the idea that those sulci, they will go all the way to the ventricle, so I can reach to the ventricle through this area. This is an idea that was developed and presented by Professor Yazagil himself. I can reach vascular lesions in this area. I can reach lesions which are passing from one side to the other by the splenium. So I can come all the way to the deeper layers. I can get close to this area, working below the splenium, along the area of the velum interpositum, along the ventricular, deep ventricular system, to chase lesions that are going in or coming out from the third ventricle. And we already know those veins. This is the internal cerebral vein, the basal vein. This is the internal occipital vein. and the posterior callosal vein, they are all here. I can also focus on the falcotentorial junction, as we saw last month. I can plan an opening here that will allow me to work with more ease towards the pineal region, or even to reach the basal surface. This is why I mentioned that the retrocallosal sector is a fun segment, because it also allows us to reach beyond the brain itself. So we set out an hour ago to check in ways to see the brain that may be useful for surgery, and we explored the medial surface with those special glasses that are able to see the layers, and we compared this medial surface to a roll cake. We mentioned that this makes sense embryologically, because the corpus callosum is the structure that organizes the medial surface in this fashion. When it's not present, we can't find this template that we are mentioning of concentric layers. We explored the outer layer, how it is formed by chunks of brain separated by sulci, corresponding to the most medial part of the lateral surface. So we remember that those are the same pieces of brain, although we may use different names for that. So we mentioned that. We mentioned that the marginal sulci are very important. They seem to be going out as if fleeing the medial surface, as in a spinning row going tangentially in this area, but we can find these marginal sulci. We can plot them along the Nasion-Inion line, along the sectors, the 4 sectors that most of the approaches along the interhemispheric fissure obey. We can even refine a few sectors based on the sulci, and we can use this idea to start to see through the skull, not to see to the lateral surface, also to see to the lateral surface, but to see to the medial surface, if that is the need of our patient. So we can improve our X-ray view. But at this point, you may be thinking, why do I need all of these? I do have a neuronavigator, right? I can use my neuronavigator and I don't need to know any of that. Well, I will then remember a very famous phrase Professor Rhoton used to say. Before I remind you of this phrase, let me tell you how did I take this picture of him. We were in a course, and this is the door that leaves the lab where he and I were, to the mess hall, where most of the people was having lunch. Dr. Rhoton had his lunch very quick and got back to the lab. And I said, Professor, what are you doing? And he said, I am feeding my neuronavigator, the neuronavigator between my ears. And he used to say that the best image guidance is our knowledge of microsurgical anatomy, the knowledge which is between our ears. Please notice that he never said the only image guidance that is worthwhile is the one between our ears. Of course, he said the best. We are not against technology, but we know that it is our anatomical knowledge that will make us analyze, criticize, correct the technology we use, if it's a neuronavigator or an intra-op is an exam. So we may want to look at the anatomy in those ways that will help us in the OR. This way to look helped me. I hope it makes sense to you, to some of you at least, and I am ready to take any questions if you have them. I will stop sharing and I will be able to answer, I hope to answer some questions. Let me see if there's anything here at the chat. There is one question if the recording will be available. Yes, thanks to IMAD, which is helping us from Pakistan in all those lectures. Every lecture is replayed on the next day, on Saturday, and it will be available. I believe IMAD is going to put in which site. Besides, we will be having the lectures available through Dr. Wen at the International Rhoton Society website in a short time, momentarily. Oh, thank you. Some people are saying congrats. Thank you very much. Can we have specific anatomic topics like temporal lobe, medial temporal lobe? Please, yes, we will. It's it is in our curriculum. It's a core curriculum that Dr. Wen put together, and we are just warming up. In the brain, we will be having several other lectures, and I'm sure we will be having the ones that you are interested in. Dr. Valerie, I guess. Thank you for being here. Some people are thanking. Thank you for being here with us. Relationship of the coronal suture and the central sulcus. Thank you, Dr. Pakesh, I guess. If I'm pronouncing wrong, let me say. Coronal suture is related to the 50% line, as we saw. It's anterior to the 50% line in the nasal line. But if we get the coronal suture and add a few centimeters, we will get to the central sulcus. So around 3.5 centimeters, we will get to the central sulcus. Remember that the central sulcus, as the pre and post central gyrus, they veer anteriorly. So the upper Rolandic point is a little more posterior than the inferior Rolandic point. Thank you very much. Some people are saying that they enjoyed the lecture. I hope the lecture helps you to re-see the medial surface with a different eyes. Kant, the philosopher, said that we never see anything in truth unless we have a model. He said that we learn things in a two-step way, that we have a theory about something and then we are able to see the thing we want to learn once we have a theory. I just gave you a theory that the medial wall is like a roll cake. That makes a lot of sense to me because roll cake is a hallmark of my state in Brazil. It makes a lot of sense to me and have been making in surgery. So I'm just throwing to you an idea. Please check and use if it's useful. Thank you a lot. Let's see if Dr. Wen wants to close the session today. Meanwhile, I want to remind everyone that next month we will be reaching the lateral surface. We will be having the lateral surface of the brain with Dr. Eduardo Ribas, which is the son of Dr. Guilherme Ribas. It's going to be a very good talk, and I'm willing to see all of you next month. The last Friday of the month is the Brain Anatomy Day. But we do have Anatomy Day for peripheral nerves next Friday. And then we have skull base on the second Friday of each month. Very soon we will have spine on the third Friday. So Fridays are days for anatomy. Please arrange your work and your Fridays around these meetings so that we can meet you all and learn anatomical surgery together. When would you like to close?
I don't see myself, but well,
we hear you well.
But it's a wonderful lecture, and we always learn something. And I saw that you make a different. You have added angiography and other things. Very nice. And I just want to thank you for partnership, for your time, and everybody for their time, for sharing with us. And we're looking forward to meeting you all of you in the coming weeks. You know, not only for brain but also for peripheral nerve, skull base. It's been truly a pleasure having you here. Okay.
When there is a question that you may answer is about how people can sign up for the lectures and how they can be um, uh, knowing in advance the topics and be part of the.
Well, how you can answer this. You're the boss. You are the leader. You're in charge of the brain's anatomy. So maybe you can answer.
Yeah, I think we do have Imad here. If you throw your emails at the chat box, I believe Imad is going to save all the emails and add you to the mail list. Also, if you go to the International Rhoton Society at Instagram, you will be finding the notices there. And but you know already that Friday is our World Federation International Rhoton Society Anatomy Day. So be smart and save your Fridays for our meetings. And I'm sure we will be having a lot of fun in the next month. Thank you very much. Thanks for your patience. Wen, thanks for
Thank
the
you. Thank you.
partnership. Thank you.
Thank you so much. Thanks. Bye-bye, guys.
Bye-bye. Thank you, Imad. Thank you very
Thanks,
much.
Imad. Thank you. Take care.